First of all, the alveoli looks like this. So the capillary is nice and tight around it, and gas exchange and diffusion can take place properly. But now sometimes you've got secretions in here, so then your surface area for gas exchange is very little. So we need to sort that out. The other problem that you can have is you've got a lot of fluid in the third space. So on your blood gas, there's one reading that you have to look at. You have to look at your AA-DPO2. AA-DPO2 is your AA gradient from the, it measures the pressure from the inside of the alveoli to the capillary. So normal AA-DPO2 is supposed to be 5 to 10. And you will see that any ventilated patients, AA-DPO2 will be around about 100%, 100 or something like that. When you go to ECMO, we sometimes start off with a 600 AA-DPO2. So this will give you an indication of the amount of third space fluid that you have to get rid of in order for diffusion to take place properly into the capillary. So those are the two things that can be wrong in your lungs when you put the patient on VV ECMO. So we drain from a vein, return to a vein. Then we've got another modality. It's called VA ECMO. Yeah. So here we always drain from the inferior vena cava, also a vein. Our little pump pulls it out, gets to the membrane. We add the oxygen. We get rid of the CO2. And then this oxygenated blood will be pushed back into the aorta via the femoral artery. So now you can see there's something wrong here. So normal blood flow will be back through the pulmonary veins, through the tricuspid into the aorta. Okay? But now we're flowing against the aorta. So that means there's something wrong with the lung, with the heart itself. So the two things that can be wrong with your heart is either you've got a poor muscle that can't contract properly, so like often an MI or something, or you've got fibrillation. So all the oxygenated blood is sitting here, but the heart's not pumping properly so it can go forward into the body. So how will you know how bad your left ventricle is? So the diagnostic test that you're going to do is you are actually going to do an echogram to see what your ejection fraction is. So what's normal ejection fraction? It's about, well, if you're very healthy, it's about 60 to 70% of this blood will be ejected forward into the aorta. So now we do an ejection fraction and we see, oh, it's about 20%. So that means this poor ventricle is very worn out and it can't actually push the oxygenated blood forward into the system. So to understand ECMO, we need to know what the patient's cardiac output is. So there's a very big equation that the perfusionists use. They use the square root of the body mass index. So it would be the square root of your length and your weight divided by 3,600 times 2.4. But we're not going to go the difficult way. So for our purpose here, if someone finds when they want to go into ECMO, we use 70 moles per kilogram for the adult people, and we use 90 moles per kilogram for children that can walk up to 12, and for babies we use 120 moles per kilogram. So quickly work out your cardiac output. So normally we say cardiac output is stroke volume times your heart rate. So the stroke volume is more or less that 70 or 90, 120 moles that we're talking about. So if I were to work out my cardiac output, I'm about 5.2. So my total cardiac output would be 5.2 liters per minute. So that is the amount of blood that my little heart has to pump per minute. So now, if we were to go, the difference between ECMO and bypass is, in ECMO we've got something that they don't have in bypass. So in bypass they stop the heart, and in ECMO we still have a little bit of function in the lungs, and we still have a little bit of function in the heart. So we can't fully bypass with 2.5 liters per minute. So we have to take a certain percentage. So in VV ECMO, we use 60 to 70% of that total blood flow there that we will tell to our patient. And in VA ECMO, we start off with 80% of the total blood flow. Okay. So if I were to go to VV ECMO, I would start my machine up, my blood flow there would be about 2.5, 2.6 liters per minute. And then if I were to go to VA ECMO, 80% of that 5.2 would be something like 4 liters I would start per minute, roughly. So if you've done your ejection fraction, it means on the VA ECMO side, you're only ejecting 20% of the blood into the system. So the rest of your organs doesn't get enough oxygen. So from the ECMO perspective, we have supported the patient the other 80% initially when it was bad. And tomorrow, I can then see, oh, but my ejection fraction has improved to 30%. So then I can come down to this one to 70%. If I carry on with the 80, it means this one is going to get better to the 30%, and I'm going to be having overshooting here. So my native heart is coming back, and my machine is working against the native heart. And by doing that, I'm not allowing enough oxygen to the brain or the arms. So you call that Harlequin syndrome, and it means you're depriving the patient from oxygenation to his brain. So we have to come down with our flow on this side to 70%, that we avoid this and help the patient to get better. And that's how you'll see that your ventricle is improving. And it's also to prevent overdistension of your left ventricle. So you have to adjust that very nicely when you're on the VA ECMO, sorry. So now you get down to about here, your native hearts are much better. And you almost went down to 20% here. But then you check your blood gases and you see that, oh, I still need some oxygenation to happen. So then what you do is, you go over to VA ECMO, which is, you'll make the Y connection here. You'll connect another cannula and go back into the internal jugular, so that you have oxygen-rich blood going in there and up into the pulmonary arteries. So that is what you'll do if you still need oxygen when you get here and you can't come with ECMO. Okay. So this is in short what VA and VV ECMO is all about. VV ECMO is predominantly gas flow, and that's important, and VA ECMO is blood flow because we take care of some circulation on this side. If you're on VV ECMO, you need a perfectly functioning heart. Okay, so you're not supposed to be on high inotropes. Your heart must be able to contract properly because you need this heart to push the oxygenated blood forward. If you're on VA ECMO, we can flow a little bit higher so that we can get all the oxygenated blood in the right places. And that's it. So we'll go. Any questions before we move on? Okay, so we'll go on to the presentation now again. Okay, so if you look at both these pictures, the VV ECMO one, the first one, is we drain from the inferior vena cava, our pump pulls it out, just to recap, and we push it back into the internal jugular. There's many other cannulations that you can use, but this is predominantly what it's all about. Then if we look at the VA ECMO, we drain also from the inferior vena cava, and then it goes back into the aorta. Okay. All right. VA ECMO. So just to recap again, this is for heart and lung support. The drainage cannula is, like I said, in the vein. And it's important to see that the tip of this cannula is below the heart shadow when you do an X-ray. If it's higher up, the possibility is there that you can actually drain too much of the blood out of the atria and the ventricle. Then the return cannula is placed in an artery, usually the right or the left femoral artery, and we use retrograde blood flow, which is against the normal blood flow. So we increase the afterload and we decrease the preload with this modality. And you can see there that we need to start off by supporting 80% of the patient's normal circulation. And this is blood flow driven. Okay, so that is VA ECMO. So the indications. So when When will we put the patient on ECMO? So the patient must have a reversible condition. And this is when you won't put a patient on there that's in cardiac failure and a chronic cardiac failure if you're not sure that he's going to have a heart on the other side to be transplanted. So, and otherwise the patient must have a reversible condition. So when you've maxed out all your pharmacological options, this is where we will put the patient on ECMO. So whenever you maxed out your adrenaline micrograms per kilogram, so normally it's anything between 0.5 and 1.5. If you are on 2 micrograms per kilogram of adrenaline, you've actually maxed it out. So what happens now? Your patient's lying there. He's been there for a while, and you can't seem to be getting his blood pressure optimal. So he's got a blood pressure of 70/20, and then you start your adrenaline, and it doesn't want to help to improve the blood pressure. So you increase the adrenaline. And while you are increasing your adrenaline, you're actually constricting these vessels. So as you go up with your intropins, anatropes, you're actually going to cause more stress on your vessels. You're going to constrict them more. So now you start maybe phenylephrine or noradrenaline, and it even constricts those vessels more. So in that time that you're actually squeezing these vessels, they're not getting any oxygen. And that's all your poor body wants. You want some oxygen on the other side. So you need to put the patient on ECMO so that you can come back with your inotropes to a therapeutic level. Okay, so all your body wants is a little bit of oxygen from the ECMO side. So that's where you'll be maxing out your pharmacological things, and then you need to think about ECMO. Pulmonary embolisms is one of the nice things that we can put the patients on for. So what we have is we've got a surgeon in our area that actually does a cath lab procedure where he goes in femorally and he bombards the embolisms with actylase, and he sucks out the clots at the same time. We'll put them on VA ECMO before we start off with the procedure, and they actually go home after this situation. And just be sure that you have less than 20% flow to the one side of your lungs before you do this, before you put the patient on ECMO. So that's the indication there. Cardiogenic shock. So in VA ECMO, it's all got to do with your cardiac output. So where you've got a decrease in your cardiac output, you'll put your patient on VA ECMO. So we've got great success. We've had a few of those that we put the patient on VA ECMO when they came in after an AMI. And it's important that this is kind of ECLS as well. So you need 2 teams when you want to do this. So you'll have to have a witnessed cardiac arrest as well. So the one team must be doing compressions while the other team is doing the cannulation, because as long as while you're doing the compressions, you've got blood flow. As soon as you stop that and there wasn't any good CPR going on, you won't be able to cannulate the patient. So while the one team is compressing properly and getting the blood flow going and keeping the cardiac output going and protecting the brain, the other team will be placing the cannulas in the right place. Then decreased cardiac output. This is all your shocks. So your cardiogenic shock, your septic shock, hypovolemic shock. These patients you'll put on VA ECMO. Drug overdose. This is street drugs, or you can also put patients who have been taking poison and stuff. They normally have a high PCO2 of about 220 or something, and they also have a very fast heart rate, like 200 or something. And then you put them on ECMO. You can reduce the heart rate slowly by giving medication or letting them detox, or you can, and then you can at the same time also reduce your CO2, your PCO2 at the steady pace. And they actually do well afterwards, provided they won't use drugs again. Then hypothermia. We will put hypothermic patients on VA ECMO and not on VV ECMO. And the reason for this is in hypothermia, your patient's metabolic rate slows down to a state where the heart sometimes stops. So in VV ECMO, you still need a perfectly functioning heart to actually push forward the blood into the aorta. But now in hypothermia, you don't have that because the heart rate's dropping. and you go into a bradycardia and maybe your heart's slowing down too much, and then you need to put the patients on VA ECMO so that you can protect all the other organs on the other side. Then, and this is also very important in VV ECMO. So if you have a patient on VV ECMO and you're not heating him up or keeping his temperature between 36 and 37, he is definitely going to get a bradycardia due to the external part of our circulation, because most of his heart is circulated outside and cools down tremendously fast. So we need to heat the patients up and protect their temperatures. As soon as the temperature drops in VV ECMO and you're not treating it, your patient's heart's going to stop and you're going to resuscitate him and you're not going to get him back. So it's important to check your patient's temperature and keep it between 36 and 37. That's very important, especially in VV ECMO. Then witness cardiac arrest, like I said before, we need to have a witness cardiac arrest and we need to have a return of circulation within the first 30 minutes. They actually advise, if you want to go into ECMO, that you do it within the 30 minutes, starting having witnessed this arrest. Then persistent arrhythmias, we can put the patient on ECMO and then sort out the heart rate. So ECMO is actually just something that buys you time while you've got something else to sort out. So it's either your heart that's not functioning well and there's a contractility problem. So if we put the patient on ECMO, we give oxygen, because when the patient starts going to having got like a septic shock or a cardiogenic shock situation, they normally have a high heart rate, and that's how they want to try and get all the oxygen that they want into the system. And by going on to ECMO, we provide the oxygen that they need. So then we can slow down the heart and sort out whatever is. It actually buys us time. So you won't put patients on ECMO because it's an emotional thing. It's not because it's my mom or my dad that's lying there and it's a last resort. This is an assist device. So in VA ECMO, there's two scorings that you can do. You can do the SOFA score or the SAFE score to see if your patient has got a possible chance on ECMO and it will survive well. And then, like I said, it's also a bridge to transplant. So if your patient is in serious cardiac failure, you must know that you are going to put him on a program where he's going to receive an LVAD or an impeller, or he's going to have a new heart. Okay, so that's VA ECMO. So now if we recap VV ECMO, it's used for the respiratory support only. The patient must have a normal cardiac function, like I've said. Then it has got no influence on the patient's hemodynamics. So this is purely gas flow dependent, and this is what we are busy with. So we give the alveoli a chance to recover when we're on VV ECMO, but your patient must be on low amounts of inotropes and no real cardiac output problem. Then the drainage cannula is placed in a vein, and the return one will also be in a vein. Okay. And like I said, it's gas supply dependent. Okay. Indications for VV ECMO. The patient must have a reversible condition as well. We do put PCP and PJP patients on ECMO, provided they're in remission and they are well looked after, well nourished. They've got a good CD4 count, and they are on ARVs. We have had good outcomes with those. So the main thing here that we want to treat is hypoxia, where the lungs aren't able to actually convert the inhaled oxygen into the body to oxygenate the body, or hypercapnia, where the patient can't get rid of the CO2 when he's inhaling. So that's what we will treat when we go onto VV ECMO. And that means the oxygen demand versus the oxygen supply is in an imbalanced state. So, well, I say there are no inotropes, but it could be low doses of inotropes as well. So SpO2, we will start off at about 40 to 60%. Now, SVO2 is your venous saturation. So I'm just going to show you on the board how this works. Okay, you can see me. So normally when we our SVO2 is measured on the right side of the heart. So where the superior and inferior vena cava meet one another and they open up into the right atrium, this is where you measure your SVO2. Okay, so that's your central venous saturation. And then your SAO2 is your most oxygenated blood coming back to the heart via the pulmonary veins, and that would be measured here. Okay, and this is the one that we read on the monitor, and this is the one that we will see on a venous gas or on. Oh, sorry, this is SAO2. Sorry, man, I'm confusing you. Luckily, I've got Rosalia to show me. Okay, so your SAO2 will be measured on your probe on your finger, and you will see that on the monitor. The SVO2 you will be able to see on the venous gases, or on our machine it will be displayed 24/7, so you can see what you're busy with. So initially, what happens is when you're 100% saturated, your HPs look like this. So they can carry around 4 oxygen molecules. See? So as this HP enters in here, and goes through the valve, it goes up into the aorta, then the HP move around, you use some of the oxygen to move your arms, you think a little bit, you breathe a little bit, you urinate, your bowels are moving, you're walking. Then this HP travels back to your right atrium. In this whole process, your HP has lost 1 oxygen molecule. So if you were 100% saturated and all 4 were full, now you've lost 1, so now your VO2 would be 75% if you're a normal person. When we get ALDS patients, they normally come in with a 75% SaO2. So that means they're already in a deficit. They've lost 1 oxygen molecule because the alveoli aren't working properly. So this carries on here. The same happens. They also lose 1 oxygen molecule, and we will start off with about a 50% SVO2 in those patients. So SVO2 is a very important thing to look at when your patients are on ECMO. So the 4 things that can actually interfere with your SVO2 or lower them is, first of all, you're not giving enough oxygen. Your PO2s are low, and you're upping your FiO2 and it doesn't work. The other one is it's work of breathing, work of anything where your patient uses energy. So when you've got a awake patient on ECMO, you will see that the SVO2s will also fluctuate according to the energy usage that's happening there. Then if you're on VV ECMO and your patient becomes septic, then it means you've got a cardiac output problem now. Okay, so now your cardiac output is going to drop a little bit. Your SVO2s will drop. Then it actually means you need to change from VV ECMO to VA ECMO to accommodate that, because the heart's not contracting properly. So septic shock, cardiogenic shock, all those things will happen, and you need to opt for a different modality. And then the 4th thing is it's HP derived. So the HP carries around your oxygen. So we want you to have your HP levels at about 10, which is not optimal. I mean, males are supposed to go up to 17, ladies to 15. So see that your HP is above 10, just to carry around your oxygen properly. Okay, so that will also be one of the things that you have to look at in SVO2. Okay. Okay, so this is also one of the things that we have to look at when you put your patients on VV ECMO is you will be maxed out on your ventilatory settings. So when are you maxed out? So you've got a PO2 and a CO2 of 50 on your blood gas. You're on 50% FiO2. Your tidal volumes are maximum 6 to 7 liters. And your rate is about 6, and your pressures are 25. So now you start fiddling with your ventilator. So you'll up your oxygen levels, or your fraction of oxygen to 100%, but your PO2s will still be 50. And your CO2 You'll try to manipulate with your tidal volumes and your pressures and so on. So now you're on a rate of about 20 and your CO2 is still not getting where it's supposed to be. When you see that in a situation, you get to your patient during the walk of the morning or the day or the whatever, you see that you can't manage your patient with your ventilator and your PO2s and your CO2s aren't improving. Then you have to think maybe I should actually go onto VV ECMO because you have maxed out all your ventilatory settings. So when you see that you can't get any better blood gas values, then we have to go on to ECMO. Before you, if you decide on ECMO, first put your patient in a prone position. If they improve within about 8 hours, we don't put them on ECMO. If they don't improve, then you definitely have to put them on ECMO. You're also going to look at your the two scorings. So the two scorings that you're going to do is the Murray score and the RESP score. And you're also going to look at your PF ratio. If your PF ratio is less than 100 millimeters of mercury, then you can put your patient on ECMO. And if they are fitting the criteria for those two scores that I've talked about, then you can put them on ECMO because then they'll have a probable outcome on ECMO. And yeah, that's it. So just to recap, VA ECMO, we take care of 80% of the blood flow. So it's blood flow dependent. The cardiac output will become higher and the blood pressure will improve. And we take care of the gases and we can still manage our gas supply with sweet gas and the oxygen that we give. So you'll see that is for heart and lung support. In VV ECMO, it's flow dependent, blood flow dependent of about 60% of the patient's total blood flow. We give oxygen fast and there's a lot more delivered in a short period of time. Because remember with VV ECMO, if you're ventilated, you still have to get the oxygen in via the bronchus into the alveolar, into the mucous membrane, and then it has to diffuse into the capillary. But now that can't happen because either of secretions or third space fluid. So when we go into ECMO, we're already in the blood. So we bypass the breathing part, the inhaling part. And then we still take care of the gas with the sweet gas and the oxygen. So we will manipulate those two to get the CO2 within normal limits. Okay. Yes. Any questions for today?
Anybody there?
Are you happy?
We are happy. Thank you.
A pleasure. Any questions? Dr. Naughty?
No questions for me.
Okay, perfect.
Then we can conclude, Boss Mandy.
Okay, then I think we are done. Did you learn something?
Yes, we did.
A lot.
Okay, perfect.
Guys, thank you very much.
Thank you.
Thank you very much for lovely talk.
Leon,
Looking forward to next week.
maybe we can send out some documentation. There were 58 people plus more in the room, I'm sure. We need, if you haven't registered because you've been a few in a room, can we please have a register of you so that you can at least have an attendance certificate? And then maybe we can send out some basic information on ECMO. Antoinette and Lizelle, if you send that to me, I'll send it to all participants.
Okay.
Leon, can we close this one off? Thank you, guys. Appreciate it. Bye.
Thank you.
Have a good day.
Thanks so much.
Oh, it's a pleasure. Bye-bye.
Thanks, bye.